talk about a lot, but I think we really need to acknowledge as mental health providers and physical health providers, and how do we just support people and support the community as we go forward. And general resources, there's a few in the community that can be really, really helpful. So if you could advance the slide. So just an overview, eating disorders are severe, multifaceted, brain-based illnesses. What I mean by this is they're so complex and multifactorial that it's biopsycho and social in nature. People have to have this biologic component, they have to have the right psychology, they have to have the right kind of social setup to develop this. And it's definitely not a choice, although we in America definitely say, oh, this person's choosing to starve themselves, this person's choosing to eat themselves into an early grave, or, whatever other distorted thought we might have. It's definitely not a choice, and we see that so much that this judgment has really impacted so many of our folks. So it's actually the second highest rate of mortality in all of behavioral medicine. So the only thing that supersedes this right now is truthfully opioid overdoses. And this is due to medical complications, like people's hearts will literally stop. Their organs will shut down, or other complications of malnutrition. The other second kind of component of this is really suicide. These kiddos, speaking from my experience, are some of the most at risk for attempting suicide out of every group that we have, even more than major depression. So when we're seeing kids, young adults, or even older adults with eating disorders, we need to make sure that we're addressing suicidal ideations or really emotional dysregulation, because they are very, very much at risk. Eating disorders can impact anybody with a body. Like, it doesn't matter your age, your weight, your size, your gender, your assigned at birth sex. It doesn't matter. And this was once believed to be a white girl's illness. But this is really something that we need to acknowledge. Men are very much underrepresented in this category. People of gender minorities or sexual minorities are really underrepresented in the research. And it just really doesn't matter. Anybody with a body. And this is one of the new Academy of Eating Disorders pushes. They've really recognized no weight, like the weight really isn't the category, right? So people who lose 5% of their body weight with atypical anorexia and have cognitive symptoms have a severe illness. So it really doesn't matter if you're underweight. That's not the concern. It's the degree of your symptom. And immediately it requires appropriate care and triaging to a team who can really support this person's illness. So if we could advance the slide. These are currently the diagnoses recognized within the DSM-5. I do think there's going to be an expansion of this with the next DSM. The most typical that we can recognize is really anorexia and bulimia, and I won't go through the diagnostic criteria with each one of them, but in general, anorexia is a restriction of food intake leading to a low BMI or body weight. Bulimia is a cyclical binge purge behavior. Purging is kind of the criteria that we use with any of our folks who kind of try to undo what they did with the binge. So vomiting, laxatives, diuretics, exercise. There's even a food debt that people try to say, like, oh, I can't eat for the next 4 hours, I can't eat for the next day. They would still fall within bulimia. Binge eating is kind of similar to bulimia, where you have this loss of control and eat more than what other folks would probably eat within that same discrete period of time, but they don't typically have the body concerns or the compensatory behaviors that are found within bulimia. Avoidant restrictive food intake disorder is kind of new and emerging, but it's something that's definitely upticking. And these are folks that are typically on the spectrum, although not necessarily. And they have lots of rules around textures, flavors. They may have had adverse reactions to food or kind of along that specific food phobia spectrum that we want to pay attention to. And then other specified eating or eating disorders that I made a mistake on my slide. This would be anybody who meets most of the criteria, but not every single facet. So that would be like atypical anorexia, which we're seeing more and more of as people are acknowledging, okay, this is a severe illness, even at a higher weight. So I believe there was a TikTok superstar who came out recently and said, you know, oh, hey, I have atypical anorexia, and she was really shunned by the media. And that's something we want to acknowledge. People at any weight can have anorexia. It's just, we don't want them to drop too low because their brain can be malnourished at any body size. And then an unspecified feeding or eating disorder is something that's kind of a preliminary diagnosis. You know, we're like, yeah, there's something here, but we're not quite sure what it's going to fit under. So that would be a diagnostic criteria that we would use, or coding that we would use. So can we advance the slide? Something that I wanted to make sure to talk about was vulnerable groups. That obviously those of us who work with eating disorders can easily and quickly recognize, but maybe the rest of us don't. Those of us that first comes to mind for me is those with trauma. You know, specifically sexual trauma they're very vulnerable to develop eating and feeding disorders. Whether that's binging to cope with negative mood or emotions, or restricting to fade into the background. I've definitely had patients come to me and say, you know, I just want to disappear. And sometimes they will just restrict their food intake so much that I just don't even want to be seen. So this is something we want to pay attention to, and we want to get these patients connected as soon as possible to both treatments, both trauma and eating disorder treatments. There was a recent study that was done with veterans where the increased number of traumatic experiences that they experienced while deployed increased their rate of eating disorder behaviors. So it's not just, you know, kids or women or, you know, people who are weak. It's across the spectrum. You know, trauma really rewires the brain. And so we want to really recognize if there is some eating disorder behavior, we want to address that before most other things outside of acute suicidality or self-harm. That probably needs to come first, especially if they're malnourished. Males are another under-recognized group that I think is going to be much more present in the new literature and research. These folks don't present the same as, you know, these emaciated girls that we see. They don't purge in the same ways. They actually tend to start off in much larger bodies and then drop really quickly. These guys tend to over-exercise and be much more concerned about being larger. So something we can pay attention to is the Adonis complex, or even turning to steroids. We really want to help support them too. These guys tend to be sicker than some of our teenage girls that we see. Their symptoms are much more egocentric. They feel good. People feel good when they move. So why don't they feel good when they exercise, right? Or they get praise from the community saying, hey, oh, you look so much better, you're lifting so much more, whatever. So they're very much vulnerable. Athletes kind of in sync with that, there's this culture that kind of says, with certain groups, hey, you need to lose weight to perform better at this, or go further with this, or have more endurance, or you need to restrict food to X, Y, or Z, or you need to watch your macros. So kind of the culture is something we want to kind of challenge to make sure that they're actually falling in line with their body's specific needs. The LGBTQIA plus and the alphabet soup continues to grow, as we all know, is a huge portion that I am really passionate about. And so kind of just in general, this group experiences a lot of trauma from culture, as well as family members, as well as just wanting to be themselves when their bodies aren't what they want. So kind of specifically within the gay community, about 50% of gay folks could screen positive for an eating or feeding disorder. So we really want to acknowledge, okay, you're vulnerable. We need to ask the questions. We need to see what's happening here. And then make sure that we're having appropriate support around that to make sure we're not inadvertently perpetuating it. Speaking personally from the gay male community, there's this goal of being lean but muscular, but also something more than what is probably humanly possible. And that's a lot of pressure. So I hope our community can kind of help support these folks. Within the trans community, which is another community that I'm really active in helping out, about 73% of folks are screening positive for an eating or feeding disorder. So we want to make sure that we're also asking these questions, about not just how do you feel about your body, but what are your eating habits? What's that look like? What's your concern about your weight? What are you doing? This is specifically common in trans mask folk. So people who are trying to lose weight to have a flatter chest. There's a movement in the community a few years ago that was called fat cycling. So whenever they were starting on hormones, they were dieting and then binging to try and make sure that the fat got redistributed to kind of the appropriate spot in their mind. As we know as healthcare professionals, that's probably really dangerous. And really compromised some aspects of their health, whether they were restricting and compromising cardiovascular health, or increasing their cholesterol or blood pressure. There's a whole host of things that we want to be mindful of. Food insecurity is another thing that here in West Virginia we have to be really mindful of. We are in a food desert. We want to say, oh yeah, just eat healthy. But for folks who are in the mountains where the biggest grocer is Dollar General, that's really challenging, or money gets really tight. We need to really recognize this is a group that we want to help support and kind of connect to resources more than anything. Anybody who has a family history of eating disorders is also kind of vulnerable. So somebody has bulimia, or somebody's grandma has bulimia, they are also vulnerable to any of the other eating disorders. So actually screening for that will kind of give us insight. Also, family values gets translated down. I know my family is very much a food family, and that's how my grandma and great grandma showed love. They're like, oh, I made this cake, eat this cake right now. And that causes a lot of pressure for people, especially people who are struggling with their own body image, or are just trying to recognize their own boundaries of, I'm not hungry, grandma. It doesn't mean I don't love you. I just am not hungry right now. So we want to explore that with our kids, especially adults, because that will be something we want to teach them so they can teach their kids. And then obviously COVID. Oh, Jesus, COVID. That's been an extra confound. Many of our eating disorder patients have had a dramatic increase in symptoms. Whether, nobody I think can really say 100% why that is, but I think there's a number of reasons across the board, whether that's TikTok, like this is what I eat in a day, probably not helpful for our kids to see. Or, oh, do this workout because that's going to make you skinny. Since you're in quarantine, you might as well do this. Or some of the other things that I've seen around the board are, what else have you done, or what have you achieved during quarantine? If you haven't done what I've done, then you're nothing. Those things really tend to perpetuate eating disorders. But something else that several of my patients who've actually contracted COVID have experienced have been the loss of taste and smell. And so when they have that, their motivation to eat is actually quite less. So those who are vulnerable are much more at risk to dropping weight, becoming medically unstable, and really compromising their health overall. And kind of going back to one of those first points that I said, about it's not a choice. Sometimes people can just have weight drop for medical illnesses, and that causes this cascade that causes them to restrict or triggers this biologic and psychological urge that is outside of their control. And so we want to help support them with that. If that makes sense, and I can answer more questions about that later. But if we could advance the slide, because I do want to keep on time. So screenings and assessments, these are just the three that I really like the best. If I'm just kind of curious, I will use the SCOFF, which is super easy, non-invasive at all, but it's a 5-question screener, which is on the next slide, but super easy, love it. It talks a lot about kind of just in general, how you feel about your body, how you feel about eating. And so we'll talk about that here in a second. But the E26 is really also easily disseminated in a primary health setting. It's 26 questions on a self-report. Really great for teens or young adults who don't want to talk about this out front, and you can have them fill that out before the appointment. It also has about 5 questions at the end that kind of helps you to assess severity of symptoms. Love the E26. It covers everything from eating to body concerns. Really advocate for that one. And then the EDEQ is a self-report questionnaire that is, I think it's about 3 pages, but it provides a great structure, and it's also a self-report for what eating disorder symptoms actually look like within about the last month. There's the eating disorder exam, which is a semi-structured exam for interviews. Also really great, but the EDEQ I feel is really robust and has great evidence for it. So I would advocate for everybody to use at least one, if not all 3 of these, to help us kind of assess what all symptoms are really present for these patients that may have eating disorder symptoms. So if we could advance to the next one, thank you. So the SCOFF, like I said, 5 questions. Do you ever make yourself sick or vomit because you feel uncomfortably full? And so my other slides, I had edited them a little bit more to say like the sick was the S. Do you worry you've lost control, so the C, over how much you eat? Have you recently lost more than 1 stone? So this was found in the UK, so about 14 or 15 pounds in a 3-month period. Do you believe yourself to be fat when others say you are too thin? And would you say that food dominates your life? Each one of these positive reports is 1 point. A score of 2 indicates a possible eating disorder and wants us to kind of delve deeper into that. If I could add a qualifier with men, if 1 is positive, we need to dig deeper. Okay. So some signs that we want to watch out for kind of in the community and our loved ones and our patients and our students, whoever you have, is really weight loss. Weight loss doesn't mean everything, but it is one of the more concerning ones, because that means they're doing something extra. Rigid rules around food or eating. This can look a lot of different ways, whether that means I can only have dinner, I can only have lunch, I have to dissect my sandwich, I can only eat 6 grapes. There's a ton here. And so if you get that sense of like, oh, this person's really stuck, or they're really struggling with rigidity around food, eating, body, that's something to kind of question more and see if we can delve more into. Excessive or compulsive exercise. The most concerning for me when I see somebody is actually the compulsive nature of their exercise. Like, sure, people can run a marathon, people can, bike 47 miles. I don't know. I don't do that, but it's the compulsive nature that's more concerning. Like, oh, I had this Oreo, or I had this piece of popcorn, so now I have to go and do this. That's the more concerning, and what the literature kind of shows is kind of more symptomatic, is if there's that compulsive nature, if they can't rein it in, then they probably have that eating disorder quality that we really want to help support. Body checking is something that's actually really subtle, but I would really ask y'all to observe some of these patients. What do you see when they're sitting in your office? Are they pulling at their clothes? Are they touching their hips? Are they wrapping their hand around their wrist? I had this one patient a couple of years ago, and in my first interview with her, she did this interesting thing. I don't want to say weird, but interesting thing, where she wrapped both of her hands around her neck at the same time while we were asking about, like body concerns, weight concerns, eating concerns. And I was caught off guard. I was like, well, what are you doing, girl? And she admitted to me, she's like, oh, I didn't even realize I was doing that 100%, but I was checking my neck. I was checking to see if it was bigger. She hadn't had anything to eat. She hadn't had anything to drink that day, but she felt that anxiety, that compulsion to check her body. And so you'll see that, whether it's somebody rubbing their hand across their collarbone or down their ribs, adjusting their clothes. Those are some things that I want you to pay attention to, as well as like sitting on the edge of the chair, or increase in fidgeting, actually. There was a piece of literature that kind of came out, it was probably 4 years ago, where people who fidgeted more burnt like 7% more of their calories than the rest of us. And so some of these kids and young adults will look into this literature and know more than you or I or anybody else in healthcare, because they're obsessive with it. And they will inadvertently pick up these things. And so just be observant, be curious, ask, what's going on with that? I just noticed it. Your hand is on your collarbone, or both your hands are around your neck right now. What's happening? And just help support them with that. So secretive eating is something that's also so important for all of us to know, because that may indicate binges, but it might also indicate like rigid rules around food. Like, I can only eat after 9 p.m. Or, with intermittent fasting, that's been a big thing that we've really struggled with our patients. So I can't tell you how many patients I've had that have stuffed candy bar wrappers under their bed because they're like, oh, my family doesn't approve of candy or da 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 da. And so I can't have it. And so we want to just be mindful. Like secretive eating is one of the pieces we really want to address. Laxatives, diuretics, and weight loss pills are super dangerous. Oh, sorry, Colleen. But so something that we want to make sure that we address is laxatives, diuretics, and weight loss pills are not effective for any of our patients. Laxatives work beyond where calories are going to be absorbed. Diuretics, you're just going to absorb it back whenever you drink more fluids. And weight loss pills are just caffeine, and you know what? It's probably going to trigger a binge. So we just want to be mindful about that. Other things, mood changes, anxiety, increased depression, irritability, those things, any major mood change in addition to any of those other things on the left are going to be things we want to really hone into. So if we could advance the slide. Consequences of this are going to be really resonating through every body system. Eating disorders are one of the few medical concerns that do impact everything. I mean, it really makes dermatological, so our skin, hair, and nails are going to be impacted. Our skeletal system is going to be impacted. Cardiovascular, respiratory, digestive, even our neurons are going to be impacted by this. So we really want to recognize and communicate this to our patients in a developmentally appropriate way. This is not just I'm just on a diet, it's fine. No, you're like breaking down your body, it's causing consequences. Typically, there's social consequences as well. Like, oh, hey, I can't eat regularly with my friends or my family. I have to follow this rigid regimen. Or I feel so anxious that I just can't tolerate that. Emotional distress is going to increase around any thoughts around body weight, food, shopping, which I don't know about you all, but I love to shop. So that would be really distressing. Yeah. And then financial, like the healthcare burden is huge for these patients. They're very expensive to manage on a healthcare front, let alone if you're experiencing other things like, oh, hey, I have to buy a whole new wardrobe because I'm in a smaller body than this one, or I'm in a bigger body than this one. Or, oh, I'm going through binging episodes where I'm eating, $40 a day worth of, Buffalo Wild Wings or whatever. There are pretty major components that we want to recognize. And actually, Credo, so the Center for Research on Eating Disorders from Oxford, is really great. They have an amazing PDF that talks about the consequences for many groups of folks that you can kind of hand to your patients and be like, do you experience any of these? Do any of these sound familiar? And I think that's great for all of us to review just as we're working with these folks. So we can advance the slide. So obviously, I think I'm taking a little bit longer than what I had expected, and please forgive. So obviously, share genuine concern, right? Like nobody gets better without true caring, right? So you have to kind of really connect with the person and say, hey, whatever, I love you. I want you to be okay. And that's the first step in for me, at least. If people don't think I give a shit or they don't think I care, they're not going to listen to any of the next things that I say. So while I'm doing that, I'm also assessing the stage of change. Like if they're pre-contemplative, I have to find evidence to help them see, hey, this is actually what's happening. This is why you might need to change, right? And so we might need to use some of those motivational interviewing skills. Really, what do you want for yourself? How is this not aligning with what you want? And then work from there. Obviously, getting family and loved ones involved is one of the best things that we can do. I don't want to say the most important things that we can do, but one of the best, because they hold so much power and allow us to move these patients forward. And so I really want to advocate that families are our best resources, because it used to be, hey, these folks, like parents were the worst thing for them, right? So it used to be thought like moms made their kids anorexic. And research has really proved that wrong. So we really want to make sure that we're providing appropriate familial support. Or even, I've had roommates of college students, I've had coaches, I've had partners, anybody who really cares about them needs to be involved. And you can do that through your first interview, like who's important in your life. And then ultimately connect to treatment. I think it really needs to be a specific eating disorder focus of treatment. If something else is primary, sure, treat that, but also we need to recognize eating disorders tend to consume all and really derail all other treatments. Okay, you can advance the slide. So in general, treatment needs to be some combination or all of these. Mental health therapy, family-based treatment is great for younger folks. So anybody who is under 18 or even in college, that's great. CBT is wonderful for anybody who's older. Adolescent focused therapy is a new and emerging research therapy that is also great for those who can't be in family-based treatment for like trauma, or their family is just not involved or can't do it. That's great. Any DBT skills that you can impart to these folks will be helpful. Medical stabilization and monitoring is really important. So we really need kind of a pediatrician or a PCP on board who can watch their heart rates, who can monitor their labs, those things. Psychiatric kind of care is also important. Just a quick note, I'm not a psychiatrist. I can't speak 100% to this, but the literature kind of shows SSRIs are not as effective in those who are low weight. Prozac is helpful for those who are purging. Zyprexa tends to be helpful for those who are kind of restrictive, although not always. So everybody needs to talk to their doctor and figure out what's the right fit for them. And then our team works specifically with a dietitian who is well trained in eating disorders. And so this is really helpful in kind of understanding what's a meal really look like. What's your nutrition really kind of comprise of. So a lot of these folks will say, oh, I can't have carbs, or I need so many macros of this or that. And so they're super helpful at challenging that and being like, actually, maybe you don't need that. You don't need X number of grams of protein to your body weight, because that's not how our bodies work. So really love having our nutritionist on board who's really awesome. So you can advance the slide. So treatment obviously needs to take several avenues. Inpatient medical stabilization may be important. Up to 1/3 of patients might need medical stabilization. And so that number comes from my initial training when I did my training at Stanford for pediatric eating disorders. That number may have shifted a little bit, but that's kind of what's been modeled here with our outpatient eating disorder treatment here at Morgantown. Partial hospitalizations, kind of 50-50, kind of back and forth. Intensive outpatient, just multiple appointments a week with one or all providers. And then outpatient treatment will comprise of all or some combination of these primary providers, so a dietitian, a PCP, a psychiatrist, and a therapist. So you can advance it. So prevention, I think, obviously I could talk for days and days and days and days. Challenging diet culture, I think if we really check what's in our fridge or what's on our shelf in our own pantry. There's probably some diet food. And so kind of acknowledging diet culture has permeated everything in American culture, and there's a false belief about the thin ideal. And I really want us to hone in on that. You know, just because you're thin doesn't mean you're pretty. It doesn't mean you're smart. It doesn't mean you're a good person. But that's at the core, right? So when I really sit and talk with these patients, they're like, if I'm not thin, I'm not lovable. I'm not okay. I'm not enough. And we really have to kind of challenge that of like, that is such BS. That is not at all what's happening. There is a huge weight bias, especially here in West Virginia, as we're combating the opioid epidemic. Healthcare providers often will say, oh, you need to lose weight, when some people are totally fine and they do not need to lose weight. Just because BMI was kind of at a certain point. And once again, I would be happy to talk about how BMI was developed. And let me tell you, part of it was they sent home questionnaires where people got on a scale at their house in all their clothes and their shoes to help determine this. So part of that is skewed by, you know, who knows what scale they were using, who knows what they were wearing. It was really about population and for insurance companies, not about individual health. And so we really want to kind of touch very carefully on that because people take BMI as such an important component of health, when I have people who are at a normal BMI but are incredibly restrictive and orthostatic and need to go to the hospital because their hearts are not doing well. We need to be mindful about media influences, you know, just really please, TikTok, this is what I eat in a day, like gouge out my eyes. It is so atrocious. We need to just really help support our teens and young adults for what they're consuming via social media, because some of these people work out for 8 hours a day. Some of these people get paid to look this way, not because that's how they should look or how their biology determines that they look, which is another component that we talk about a lot in clinic is, you know, weight is actually so determined by your genetics, not as much what you do. So we really want to just help support towards health in a well weight, not, or a well weight range, not a well weight spot. Increasing of awareness and improving access to care is also super helpful. Obviously, like I said, we are in a food desert. So recognizing like these people who are binging needs to really recognize, hey, you know, maybe it's because you're restricting. So this is our plug for our edit clinic. We do care for individuals up to 25 years old. Olivia DeVille is a great resource for us and can plug anybody in with us. Our physician is Dr. Somi Shore, who's great and goes above and beyond and sees people all across the state, even via telemedicine, which the rest of our therapists as well as our dietitian does as well. But Helena Sadowski is our dietitian, who you might see her name pop up through other medical records. She is also a great resource for challenging diet culture and other issues that we may have. So I think the next one is just general resources like the National Eating Disorder Association, Eating Disorder Hope, Credo. Credo has a great online training for anybody who's interested in obtaining more eating disorder training. They ask you to sign up and you do a 6-month training in tandem with a patient. Super cool, super helpful. And then the Training Institute for Child and Adolescent Eating Disorders is an FBT model. They have been full through the rest of this year so far, but next year I believe is still open. They've been doing a lot of things via Zoom. The Credo is also via Zoom, or it's asynchronous, sorry. But yeah, And then I have a few resources, some of them that I didn't talk about, but any questions, concerns, thoughts?
Yeah, I just want to say we really appreciate it. You were preaching and so many of those slides there, and social media, like you said, TikTok and stuff, it can really get to someone. So I just really appreciate you sharing all that with us. So thank you.
Oh, thank you.
Excellent job. Thank you so much. I did not realize like the high mortality rate. So that was really alarming and concerning for sure. Have any of you heard about certain countries? I believe Norway was the latest that passed legislation to, so somebody alters their photos or makes, a filter on them, they are requiring on social media that they have a disclaimer that they had done that. Do you think that that's a good idea? Do you think that'll even help? Or is there a deeper thing? I didn't know if any of you had any thoughts on that.
I personally kind of feel that it might be helpful, but it is a deeper thing. I'm coming from personal experience. Unfortunately, I think it's something that someone battles with almost lifelong. I struggled with anorexia in high school, and I'm 45 now, so I've done well for years. But recently, I purchased my first set of scales I've had since high school, and I caught myself getting on them like 4 or 5 times a day, monitoring my weight. So just to make people aware that, it may, when you're seeing an adult, maybe question about, their earlier high school behaviors and stuff, because I think it is something that you kind of struggle with deep down, probably the rest of your life.
Well, thank you so much for sharing that personal story. We really appreciate that. Does anybody else have any comments or questions? Somebody popped in a question. Can you speak to morbid obesity as an eating disorder? I want to promote body positivity and support someone where they are at to make healthy choices. Yeah, excellent question, because on the other side of the spectrum, you see that happening a lot as well, emotional eating and trying your best in that case. Matthew?
Yeah, so I can't speak specifically to morbid obesity as an eating disorder itself, because it's not, but what got somebody there, and exploring that in therapy or with their physician is really important, because when you look at the behaviors, like how did you get here, will be helpful in kind of determining what's the next step. Actually, there's some really important research that's happened recently about food companies and actually their bliss point, where they have hired addiction specialists to find the spot between sweet and savory to allow people to be inadvertently more likely to consume their product. So, so much of that is something that is on the horizon of how we're going to support folks. Weight loss management is really challenging. Even with bariatric surgery, only about 5% is successful, especially if they don't address the eating disorder first. So that's really important. If you're binging, somebody needs to address the binge eating first. If you are binging and vomiting, you need to address that first before you even pursue weight management stuff. Otherwise, you're just going to continue the cycle. If there's food insecurity, that's really a trauma that needs to be explored. And how do we make people safe with food again, right? And how do we make sure that they recognize, like, oh, okay, I can be okay with this. And, even if my cupboard is, not as stocked as I feel safe with it being, I can still be okay because I have enough to kind of get me through. So also there's been some, not to segue, but adipose tissue is also an endocrine body, right? So it releases hormones. And so when you start losing weight, it releases a hormone saying, hey, you should not be doing this because we're going into starvation mode. And so it releases another hormone saying, hey, you need to eat more. So leptin and ghrelin are really important to recognize within this kind of process around morbid obesity and kind of how to support these folks.
Thank you very much. That was a great answer. Very interesting topic, and just being kind to yourself. I think that this couple last years and in general has been really rough. And I, like Matthew, like to shop, or I'm more on the opposite. I want to eat my feelings. I'm just sitting here, you know. So I think the last year you're seeing extremes on both sides, and cases like somebody's other side of themselves come out a little bit more. So yes, thank you so much. It's like Kayla and everybody is saying, that was a really great presentation. Does anybody else have any comments or questions? Amanda's clapping. Thanks, Amanda. If not, no worries. Please reach out to me, and I could always get a hold of Matthew if you have any further questions, and we'll be sending out the recap information. All right, our next session